There is so much of blood, right, on a cadaver. I've done this. Let me show it to you. It's really simple, okay? Both subciliary and transconjunctival. Basically, it's, suppose you're talking about subciliary, it's skin, and then you have muscle. And then from transconjunctival, it is conjunctiva, and then you'll have muscle, okay? The whole point is just stay medial to the muscle. The skin and muscle have to be out, and then everything else has to be inside. Okay, whether you're going from here to here or here to here, you are just supposed to stay beneath the muscle.
Suture now for the subciliary incision. So we hold the lower eyelid like this, pass the needle from the skin through the grey line. Again hold the upper lid, hold it away from the actual eye through the grey line.
Okay, so this is the tarsorrhaphy suture. We are using silk here because it's a cadaver. Tarsorrhaphy suture, when you take it up, you have to close the eyelid so that that suture doesn't injure the cornea. Okay, very important. That is done. Then now is your marking. As Rahul said, it has to be a straight line. I'm pulling it up, that's why it's like this. But 2 mm, maximum 3 mm beneath the grey line. Okay, mark the incision and you infiltrate. Alright, now see. Skin. Okay, and you have to cut after some time you cut the muscle, and now see, the minute you are beneath the muscle, you will get this avascular plane. Whether it's a cadaver or a patient, you will get this avascular plane. What is above? It is the skin and muscle only. Beneath the muscle, you have an avascular plane. Okay, below that is your fat and your periorbita. You don't want to disturb the periorbita, just stay above. You won't be able to, sometimes when we see the periorbita, you see the fat and you just, as you keep saying the fat, don't go like this, go outwards. Okay, this is subciliary, go outwards. Alright, do not cut the muscle, do not cut the periorbita. Just go outwards, keep protecting the fat here, and yeah, see, this is your periorbita. Okay, just keep that towards the eye, keep the fat and the periorbita, and now when you are a little down, palpate with your finger, ki, acha, where is my inferior border, infraorbital rim. When you are now over the inferior orbital rim, then you will cut the muscle again. Okay, over the bone, you will cut the muscle again from medial to lateral, or doesn't matter. Now that you've done that, okay, that's it. That's it. There is no big deal about subciliary. And you have to go till you see the infraorbital neurovascular button. Okay, are we clear? Everyone, skin muscle this side, fat, periorbita this side. Huh? Transconjunctival, this is my way. There are different ways. Okay, so here we have to take 2 or 3 sutures through the lower eyelid. Injection. We go from lateral to medial, okay? So we cut like Rahul showed, but he cut it later. We start with cutting the canthus, okay? You have to have a good scissors, okay? All my scissors are pathetic, so I'll try with the scissors and then that won't work. And then I'll scream and then I'll put a knife. Government. I've screamed here. Okay, knife. So cut that. The different thing that I do, which I've not done here, is that when you cut, the same thing that Rahul said, that you have to identify and put it back. So bhai baad mein nahi milega. So at that very minute, you take one suture here for the canthus, and then just leave that loose. Put a mosquito, leave that there. I've not done it here. It's a cadaver, but you have to do that. Okay, okay. Take a suture through the lateral canthus, which you have just cut, and leave it there. I will just go back. Okay. Now, once that you put the suture there, okay, suppose, imagine. Now you can see so you have the tarsal plate here, you know where it is. This is the conjunctiva. Don't use this thick, fat, big adsense. It has to be a very small one. This is a cadaver again. Now we are cutting the conjunctiva, okay. Okay? Now, again you have to reach the same plane as you reached in the subciliary. So we are here, now we are going beneath the muscle. So the muscle has to be again up. The same plane has to be reached here. Yeah, and you've developed your conjunctival flap that Pratik showed and Rahul showed. That flap, you can take a suture through and take it up. ठीक है? See, that's covering. So you can either use a corneal shield or that conjunctival flap. वो हो गया? That's the suture. Okay. I'll show you the suture again. Suture through the conjunctiva. Yeah? And then take it up. That's to protect the cornea. Now again see, the same plane that we reached via subciliary. Skin, muscle, upper, baki sab niche. That is it. There is no big deal about subciliary or transconjunctival either. ठीक है? See, we've reached the same thing. Alright? Alright?
Yes.
चलो next. Next.
So there are now 3 types of subciliary dissection. What ma'am showed a little bit sticky because the skin, if you dissect too much, right, it might become dark later. So this is the first technique which has been described. That they cut the skin in some area, they dissect 10 millimeters down, find the muscle and cut. So the skin and the muscle is separated. It's one technique. Second one is you cut the skin, you dissect for a few millimeters, then you go and cut the muscle. And the third one is mix of both. You cut the skin, directly go to the muscle. The skin gets supplies from the underlying muscle, right? So when you are a beginner, don't dissect much. You can buttonhole, you can have lymphedema here for a long time. Remember this. Okay? There are 3 modifications for the subciliary.
Yeah. So mine is you cut the skin and you cut the muscle directly. We are maybe in a 1 millimeter or 2 millimeters. We are directly under the muscle. So there is no problem with this thing. Skin, muscle, everything on top, as I've been saying. Okay? Chal bhai. The problem with keeping only the skin is, as he said, right? The skin has its blood supply from the dermis, right? So if you have only a skin, it will necrose. It can necrose. Okay? So keep the muscle with the skin.
Skin muscle flap is easy, but can be better.
Very good, very good. So for ectropion, we have something known as the frost suture. We will show that. For subciliary, we will have ectropion as a complication. For transconjunctival, we will have entropion as a complication. That is why we, Rahul, Thakur, we do not suture the conjunctiva. We suture only this, okay, and evidence-based in the literature. But if you're happy suturing, well, okay.
Okay. So, Rahul sir, as a beginner, we all know there are mainly 3 approaches: infraorbital, subciliary and transconjunctival. But for a beginner, what would be your advice to start with the orbital approach? Because there are, as we discussed, there are multiple factors which come into the play. Which hospital are you operating in? How far good surgical assistance you have? Which are the anatomical areas which are supposed to be, which are involved in the route to be selected? Your level of confidence, your experience, your way of treating complications. I mean, how do you manage to select the best possible approach for orbit as a beginner?
So the easiest approach is the infraorbital approach, but I would urge everybody to get very quickly trained with some good surgeon who gives a good subciliary approach, because subciliary is as good as a transconjunctival in most situations, okay? Almost as good, I would say, in most situations. But I would always say, again, yesterday I told, no upmanship. If somebody is giving an infraorbital, I give a mid-tarsal, I am going to say, it should not be a selling point. If I am giving us, then he will give a transconjunctival with canthotomy and Siddharth will give a transconjunctival alone. What is best working in your hands? A good infraorbital is much better than a bad transconjunctival. Please remember that. Because if you have a problem with the transconjunctival and you run to the oculoplasty, that is not a good idea. So see what is comfortable in your hands. If whenever you are giving an infraorbital also, see that you can identify creases and stick to creases, and believe me, if you give a good infraorbital, you have a good crease, you can get away.
Okay, so we are working with the very delicate structures. So what would be the role of instruments whenever we are going for any orbital blowout management? which instrument we must not forget and which helps in making your job easier?
For me, it's my loop and light. Without loop and light, I want to operate the orbit, for sure. I need at least an illumination is important, because any good lights will not go posteriorly. So loop and light for me, and a malleable retractor for that, I think is important for me.
I just want to add here, usually what I do whenever we go for any medial or floor blowout fracture, I take different sizes of the spoon which are being autoclaved with the small shape to medium and bigger size, and based on the patient's anatomy, orbital socket size, I insert that sterile spoon onto the floor of the orbit and just lift all the orbital content. So subperiosteally and floor of the orbit, you can have a best possible visualization. Demers retractor, as sir said, that must not be forgotten, because whenever you are subperiosteally, whenever you are above the orbital septum, inferior retraction is being best done by the Demers retractor. Small Langenbeck cat's paws are again extremely important, as you discussed in your presentation.
Since you're asking me, this is a funny incident. I think first 3-4 months in my practice, I was sitting in the OPD and I was called in by a senior maxillofacial surgeon ki orbit ખોલ્યું છે અને નથી ખબર પડતી. So I had rushed in my OPD, which was hardly any, there were no waiting patients. So I went and I was very excited. And it was, the operating room was really small, and there were no floor retraction instruments, because that surgeon didn't really thought that he would have to go and repair the floor. And there were no instruments. I just walked in the theater. Andrew, you can close your ears. This is India. So I asked for a spoon. Incidentally, there was a spoon in there. So we had to put it in the Cydex, wait for 20 minutes. Thank God's name. I hope you're not listening. Okay.
So I steal spoons from places where I think, oh my god, this would be fantastic for the orbital floors. One was from British Airways.
I share one of my incidents as a beginner when I was starting with the orbit. I mean, initially we did not have a great surgical assistant, so I was used to take interns for the assisting, or maybe first year postgraduates just to assist. So for them, conjunctiva orbit was like relatively new. So one of the intern was just holding the caudal conjunctival flap and immediately went into the vasovagal shock. And with the flap, he was just like on the floor. And this is such a delicate structure. I mean, you will have no clue. Yeah, exactly.
Andrew, this is locker room talk again. It doesn't get out of here. What happens in Vegas stays in Vegas.
Yeah. So let's get back to it. So third important point, sir, we are manipulating the eyeball so much, especially in mesoorbital ethmoidal fracture or orbital zygomatic maxillary complex fracture. So how far it is important to have words with anesthetist at the time of manipulation of the eyeball and when we are playing with the muscles of the orbit, extraocular muscles especially?
Yeah, so the monitor should be visible to you and to the anesthetist, and the alarm should not be switched off. There is a typical reflex when you manipulate. Anybody? What reflex? You should be aware of it.
If it gets activated, what will do that? Pardon? If it gets activated while operating, what
You stop and you release your instrument if it's giving pressure, and and if it's a severe brady or something, then atropine.
it will come back.
This point, I think, sir, you have already discussed. Based on area involvement, ideally a surgical approach should be selected rather than just sticking to only one particular surgical approach, because infraorbital or subtisal approach will be limited to the floor of the orbit, and probably if we are extending up to FZ suture, most of the body of the zygoma, medial wall, then as you said, transconjunctival and at times even extension of the transconjunctival, that is transcaruncular approach we are supposed to consider. Your add-on to it, sir.
No, I think
Yeah. Drawbacks of subciliary and subtarsal approach, sir.
So again, I said that the easiest part is there's a beautiful article by Ed Ellis. It's an old article. It says, don't abandon and don't be ashamed of the mid-tarsal. It's better to give a good mid-tarsal. Mid-tarsal is 5 to 7 mm below the lower eyelid. So there is, most of the times there is a crease. Okay, so that's okay. You don't have to be 2 mm like Sonal madam does. If you are comfortable with mid-tarsal, go ahead and do it. It's a decent approach. The problems is the exposure over here, and a good suturing will be okay. Subciliary, the problem is that if you are not good, you will give an ectropion. That will be bad. So skin with 4 or 5 millimeters, then going in the muscle is the best way. The converse modification requires some practice.
Yeah, let me add to that. One more way, one is the frost. Have you put the frost? We have the frost somewhere. We'll show the frost. Another way to avoid ectropion, not just for this and for any part of the face, is soft tissue resuspension. Do not forget that. And that soft tissue resuspension happens here. When you dissected here, then whatever, when you pull everything back and you suspend here with non-resorbable sutures. Okay? So this is something that will hold up like this, and then this thing then finally can be held up with the frost. So, but if you have this whole thing hanging, then there's a problem.
The problem is like the video which I showed with a canthotomy, I repaired everything in one go. So that time you must resuspend. If you are going to give only a small transconjunctival, no canthotomy resuspension is not required. But for bigger zygomatic complex and all that, if you are doing, you must resuspend. Otherwise you have an ectropion which you can't correct. There are different types of ectropion. One is a cicatricial ectropion, which requires a skin graft to correct. One is a regular mechanical ectropion, which you can do a lateral strip and correct. So, but if you have no resuspension, then you cannot correct it. You have to do you have to do a facelift kind of thing to correct it.
Sir, how to prevent surgical injury to lacrimal sac in transcaruncular approach, especially when we are targeting the medial orbital wall?
So we didn't discuss the transcaruncular, so I don't know how fair it is to, because I was told, so should we talk about it?
Yeah.
So transcaruncular approach is an approach for the medial orbit. Here, I have used only a transcaruncular also, but most times you combine it with a transconjunctival. That you need to go posterior to the lacrimal crest. That is the most important thing.
Can I just add it?
Yes, please.
It's called as a transcaruncular, for ease for understanding, it's technically a retrocurricular but not transcaruncular.
Yeah. You don't cut through a caruncular, you go behind the caruncular.
Yeah, the incision should be behind the posterior lacrimal crest, so you don't damage the lacrimal sac.
No, not the incision, your dissection.
Path of dissection. So how far do you often encounter the anterior ethmoidal vessel bleed when you are chasing the medial orbital?
I always say a prayer. As you get older, your prayers get stronger. Because if you get an anterior ethmoidal injury, you are going to get blindness. So you have to see that either you are not in the vicinity or you bipolar it with a good bipolar, extremely important.
Yeah, sir. If you are getting ectropion, suppose with the subciliary we have got the ectropion, or with the even entropion at times we encounter, how do you manage it post-operatively?
Entropion is almost never that you will get it, with a subciliary at least. Ectropion is a lateral strip, but if you are careful, you are not going to get it. You have to just reattach the lateral canthus in a more anatomic position. But if you are going to be careful, I don't think ectropion is really a problem.
Just one point to it. Sir,
Yes.
subsidiary, it is not advisable to close muscle for a subsidiary.
Yeah.
Then you are likely to get ectropion.
Yeah, so I did say that. It is periosteum and skin. Periosteum and skin.
Even if you cut the muscle, you don't need to.
No. You should not. You should not.
We have read so much in the textbook regarding post-operative hematoma and retrobulbar hemorrhage. Thankfully, I have never encountered till now. But in your experience, your practice, did you ever encounter with this and how did you manage if it happened?
No, luckily I have never encountered a retrobulbar hematoma, but I'm sure, I have seen patients with trauma already lost vision. You just open up the cones of the orbit and give steroids and hope for the best.
Exactly.
Yeah. And open you're putting your scissor almost everywhere. Yeah.
Let the bleed out.
I have to add on this.
Yeah. Catheotomy, open the cones.
I had encountered a small child, maybe just 6-7 year old. He was going with his father and fell from the bike. And there was no trauma. He just had injury here and his whole eyeball popped out. And brought in the hospital where eyeball popped out. The emergency doctor tried to push it in, it was not going back. And then we did a CT, found some collection behind. Immediately I took him in the OT night 2 AM or something. And did a lateral canthotomy, released the pressure, and I just the eyeball, it went inside.
Wow.
And I had those pictures also, I shared on our common group also. So this is the importance of knowing the technique.
Correct.
And they had, I don't know, his vision was not good immediately, probably must have recovered with time because he was on long-term steroids. But that was so important, we know the technique well. Even the ophthalmologist was trying for 1 hour, then they called us.
Not only steroid, we also did catheters on the mind.
Correct.
So then the follow-up with the ophthalmologist.
The treatment for a retrobulbar hemorrhage is surgical, not medical.
Yeah, right.
Yes,
Don't CT scan them, you're wasting time.
Yes.
You shouldn't be seeing a CT scan of a retrobulbar hemorrhage.
1 hour is too late.
Too
1
late.
hour is too
No,
late.
I was called after 2 hours.
That's too late.
Then a CT scan, everything there. Ophtha was trying.
Get your scissors in as Rahul said,
Exactly.
open it up and get rid of the clot, because that's what's causing it basically, yeah? If you can do a canthotomy in about a minute, 30 seconds,
Yeah.
go in and do that. It's sight-saving surgery, and as maxillofacial surgeons we don't do this basically. Please don't give mannitol or acetazolamide, faff around with drugs and that, you're buying time. Get in there and actually be.
And bedside, it's bedside, don't wait for the OT to
No,
come.
don't wait around, just get in a pair of scissors and do it, yeah? Just do it.
Okay, coming to the last slide and last question, sir. I have never used navigated surgery or endoscopic approach, especially for...
Sorry,
Yeah,
just a
sure.
second. So do you put in high dose steroids as well? Because a lot of oculoplastic, they try to push a lot of heavy dose. Because NASA study says there is no proof for it, no proof at all. So anybody else who puts high dose steroids or anything?
Where? Just a minute.
You do a surgical release of lateral canthotomy. Apart from that, do you believe in pushing some steroids as well? Because oculoplastics and all, they usually...
Steroids for what? For elective?
No, for retrobulbar. The surgery is the mandate, no doubt. But still, they try to put a lot of steroids.
Problem is, the only answer is surgery as
Yes.
Otherwise, there is no RCT. There is no RCT.
No, even nurses say there is no
the problem
for
and
steroids.
loading steroids. I have had situations. I think last month or so, orbital fracture. Patient was loaded with steroid because he had a cord injury, and then patient had infection. So steroids for a life-saving thing, you give it, but you don't know when to use it.
Actually,
There's
nurses
no
is
proof.
against putting steroids. Actually.
Okay, last question. Your endoscopic assisted navigated surgery, how is your experience, sir?
My experience is there, not a huge amount of cases, but if it's a very bad fracture, everybody says you find the posterior ledge of bone, put your implant. Sometimes, most times you will. Sometimes very difficult to get the posterior ledge. What happens is when you are operating, if you look at your post-op CT scans, always get post-op CT scans for your orbits because that's a humbling experience. Your implant, your mesh will go down. That will not be hinging on the ridge almost. When you present in a conference, you'll always show your best cases, but it will not happen all the time. So, in bad orbital blowouts, what happens is if you're not sure where your posterior ledge is, having an endoscope telling you where your implant is good. Otherwise, your implant will not go up, which it should be. It will go down in the maxillary sinus.
Thank you.
Sir, can I just add a small thing? Not the endoscopic. I'm sorry, just take 30 seconds. In an orbital trauma, that was specifically when we do an orbital floor reconstruction, most of us, we shy around to go dissect as posteriorly as possible. Technically speaking, we need to see the ledge. We have to be able to visualize this. Unless, yes, we need to. Because what happens is when you try to dissect it, we shy around. We are scared of going in posterior. Unless you dissect and see the ledge, don't put in your implant. You need to.
How much do you want?
25 to 35. Ma'am, for me, more than millimeter, I need to see the ledge.
Yes, right.
I need to.
For beginners, how much?
35 to 35 to 40. That's what the textbook says around.
40 and how much?
No, see, basically, see, you have to see. You have an unless there is no important structure till the ledge. Till the ledge, you don't, and the optic canal is beyond it, behind it, so nothing to worry about. You have a safe dissection plane, subperiosteal, slightly. You don't have to lift up fully. Lift out, and you can manipulate yourself and able to see the ledge.
There is a very good paper on this known as the Hammer's area, right? And it is technically given in a book by Peter Wardbooth, Aesthetics Facial Surgery of the Face. It is nicely described. It's given an anatomical specimen how to dissect and how to identify the Hammer's area. So there is a paper also in it in the international journal, right?
Dr. Rahul, regarding the lateral canthotomy, when you do a transconjunctival, do you always get your, do you repair the lateral canthal or you just?
Yes, always. If you do, obviously.
I've been stopped doing it from past almost 5-6 years now. I've seen a lot of oculoplastics do it, so I've picked up on it. Just get a suture, it works fantastic. For me, I don't know.
You have to prepare
Standard textbook says that we have to.
If you don't do a canthotomy, of course that's a
No, after lateral canthotomy.
No, you need to resist.
But that's the difference from my end, so I don't do it. So it works good.
Start with doing it. If it works and if you want to not do it, later.
Yeah.
Alright.
Any questions from?
No time, later.